Baby Friday, y'all. I'm glad that y'all could be joining us today. And we are doing our healthcare happenings today with my good friend and colleague, Faith McNicholas, who is with the AAD, the American Academy of Dermatology. And I have known Faith for many, many years, over a decade, but, you know, because we were both in high school. But you know, Faith is great, and so we're going to talk about some derm stuff today. It's one of my big favorite things to do. That and E&M, y'all that know me know that. So I asked people to when we came on, Faith, if they could kind of put up like where they're coming from and things like that. So we have Lady, who is a frequent attendee. Nice to see you again, Lady. She's saying happy Thursday. Pam, another frequent attendee, is in sunny Florida like me. We have somebody in Maryland, so up more towards your neck of the woods. Poor Faith is in Illinois, and she's got, what, 36 degrees, you said?
36 degrees. So please do not talk about how warm it is in Florida. It's just not fair. It's illegal to talk about your temperature.
And Kimberly Jolivet Williams is joining us again. Hey, Kimberly, good to have you back. And she's in Garland, Texas. So we get a nice a smattering around here. And so as usual, for those of y'all that are dialing in and for new people, Faith and I, after we have some discussion on some topics, we're going to pull some different things up and just kind of go around on things. And so if y'all have questions, go ahead and throw them up in the chat. And if it's a subject we're going to talk about, when I bring up that subject, I'll pull your comment in and we'll discuss it. Or at the end, when we're done, if you have questions that, weren't in what our little kind of pick list is, then we'll pull those in and discuss those for the time we have remaining. And we have a new person calling in where she says, Matri, and I hope I'm pronouncing that correctly, says that it's her first time and she's from New Jersey. So again, another cold one up there with you. So we got North Carolina, so we got a good Nebraska. And Pamela says, I feel you, Faith. It was 34 degrees in Maryland. So
sometimes we need misery loves company. Thank you.
There you go. It always works nice. So first, I just want, for people that may not be familiar with you, because you speak nationally and do a lot of things too, but just to kind of let people who may not be familiar with you get to kind of know you a little bit better, I just thought to ask a couple questions for you that you could kind of share some information on yourself, like bio kind of stuff. My first one was, like, how long have you been in the industry?
Oh, goodness. Do you really want to know how long I've been in? Who's going to age me? I have been.
Well, like I said, we were in high school, so it kind of, we get in there.
And we just graduated from high school.
That's right. That's right.
I have been doing coding for over 20 years now. When I started coding in cardiology and endocrinology. I used to be in a very small practice. It was a mom and pop kind of stuff. It used to be so cool because I had no idea what healthcare coding is. Because, Betty, you've known me for a long time. I come from a country where we have universal health. We don't do any coding whatsoever. If there's any coding, it's just for diagnosis, and it's just for
stats,
data monitoring. That's all. So I kind of was a little bit nervous when they told me you should put this code here, and I didn't even understand what it meant to put this code here. So I went back to my husband and I said, wait, I'm doing something illegal. We should be rethinking the strategy. This is not what I'm supposed to be doing. So that's how I got into it. And my husband signed me up for a short coding course in our community college around my town. And after that, I remember in college, my instructor telling me, whatever you do when you graduate, don't ever code for dermatology. Code for anybody else. Dermatology is not, it's very easy, boring. I left the endocrinology and cardiology practice after a couple of years. And I found this job application in the papers. And I went and smack in the wall, says dermatology. I almost turned around and went home because I figured I'm in the wrong place. So that's how I was going to run. shouldn't be here. And that's how I started in dermatology. So I went for that practice with a startup. We worked with that physician for a couple of years, maybe 4 years I worked for that. And then after that, I went to work for the American Academy of Dermatology. I've been there since then. And even though today I'm not representing the academy, I am talking
Yes.
based on my own knowledge base and what I understand about coding for as a family physician. Of course, my favorite discussion to have is dermatology, but I'm happy to discuss any other things you can throw at me.
Great. And so you've been with the AAD quite a while, right? Like 15, 17
16, I'm
years,
going
something
on
like that?
17 years now.
Yeah.
Yes.
Yeah.
So it's been a while.
So what is your favorite thing to educate on? Like, is there a specific thing that you like me, of course, E&M, anything E&M, any specialty E&M, I'm always down for a good E&M discussion. But in dermatology, like Mohs, I love, and not just the coding of Mohs, because when you look at it, as long as the documentation is all there, actual coding of Mohs is not that complex, but the actual Mohs itself. I love watching Mohs procedures and what they're doing. And, the whole thing about one-stop cancer care, for that thing I think is just amazing. So that, I really love. So is there something that you really kind of get jazzed about?
So here's how I look at dermatology coding. We have the largest anatomic system in the human anatomy. And I always feel like we have 9 codes to work with.
Yeah.
We're constantly, constantly stretching what we have to work with, which is it's interesting in itself, and it can be very frustrating. And I'm sure for those that have heard me speak before, or maybe you know me for a long time, I also am the staff liaison to the CPT editorial panel for the Academy. So I really can't say I have a favorite thing that I'd love to talk about in dermatology because I love all my children and I'm not going to pick favorites. So throw me anything. I'm happy to talk coding, especially dermatology, all day long. I love how we get these challenges in trying. In dermatology, we do a lot of procedures
Mm-hmm.
in combination with each other to get a good outcome. And if you look in the CPT coding manual, you're probably not going to find a specific CPT code that will describe the procedure that was performed. And now you're left scratching your head thinking, wait, what did we just do here? You know? So I love those challenges. I love to solve those problems when they send them to me and say, so how do we, oh, okay, maybe we should create a new code that's going to specifically describe this kind of procedure. So yeah, I don't want to be biased and say I love one technique over the other in dermatology because you never know, the children might start complaining. So I'll just say I love dermatology.
Yeah, you said you didn't like us. Now, what and that yeah, I just thought of in looking with the AMA with the AMA, you are involved with the RBRVS with the RUC and with the RBRVS committees. Is that right? Am I remembering it right?
It used to be that way until about 6, 7 years ago when we started having a little bit of a higher influx on code requests. Like we get sometimes vendors will say, hey, we got this new gadget and they think this is the magic bullet to treating dermatology conditions, so we need a code. Creating a code can be a long, tedious process. So between creating the code and if you follow the AMA program or the
Mm-hmm.
RAC and CPT program, the meetings are back to back.
Mm.
So it became a little bit too much for me to handle myself. So we kind of like split those two requirements. So I birth the code, technically create the code descriptor, create the work descriptor. What is involved in this procedure? Is it FDA approved? Um, what is it going to treat? Whatever the description and both the procedure and the diagnosis, if a coder who it does not code dermatology looks at this information, will they be able to make sense of what we're trying to talk about? And then once we finish with all that, and if it's approved, which can be a process of between 1 or 2 years, then we pass it on to our RAC colleagues who now go and start fighting about the pennies and values.
And counting the sheet paper for the
Exactly.
tables. And yeah, that's what amazed me with the stuff with the ruck was I was like, do you realize, when you sit there and think about that, like it's like every tongue depressor, every cotton swab, every, I mean, they're taking account into every little thing, to try to make sure that the RVUs for each piece are sufficient when you get paid for those procedures. And that's another reason why I always tell people, and for y'all that are listening, when if your physician gets those RUC surveys about their procedures, really pay attention to it, fill it out first, because you're never going to get paid right if you're not part of the solution. If you get one of these surveys, so instead of complaining that it's not right
Paid
payment,
well.
do something about it, be involved and help. But make sure that you're filling it out correctly for the time it actually takes you. Because I've seen before where like cardiology had that happen where they had sent out those surveys and a lot of the cardiologists were like, oh, I do this procedure in 20 minutes. And we're kind of like, like I'm the best. And yeah, well, then their values all went down.
Efficiency is not your friend when you go to the work.
No, I said, really be honest. It's not, you're not puffing yourself out. It's not a contest. How long does it take you? What are you using? What are you doing? Be specific and be truthful in length and all that stuff, or you're not going to get paid appropriately.
And the way I talk to my dermatologists when I'm talking to them about the RAC process, I'm like, there is no drive-by completion of a RAC survey. Make sure you take time, you don't have anything else going on, and focus. You
Yeah.
need to count. What you don't realize is we also count the amount of time that room is in use. How much electricity did you use? Because that's also part of
Exactly.
the practice expense. Those are
Yep.
things that we don't think about. We don't think about the sheet. We don't think about the staff that are
Yep.
spending time with you to support you during the procedures. So don't do a drive-by completion of a RAC survey. Put everything away and sit and focus and complete the information as appropriately and accurately as you can. We're looking for that typical patient. How
Yep.
often does this happen? Is this 80% of your time? And those are the values you're going to take. But if we get 50% of the time, or 80% of the time is 5 minutes for a procedure that should take 15 minutes, you've got only yourself to blame if the
Yep.
values come back negative.
That's right.
Mm.
And we have a comment from Lady. She said, it's interesting how long it takes to create a code.
Yes,
Yeah.
yes. Because when we start creating the codes, we got to think about everything. Uh, Whatever we create at CPT level is what's going to carry the value for that code. So the work description has to be very succinct. So we take the typical patient who is going to be treated with that CPT code. And then we also go and talk to other specialties who may not be in dermatology, but maybe once or twice in their life perform that service. They might have some comments that we could use.
Yeah.
So the process is just so long and tedious. And by the time we're finished, well, don't forget that when we're finished when the code is approved and goes to the RAC, it might not go into effect the very next year. It might be another 2 years before you actually see it in the book.
Yep. Yep. And is that why, because I get this question a lot, and maybe you can shed some light on it. And I just thought of it. So if you can't, is that why sometimes you'll see that, in your opinion, that you see groupings from different specialties? Like one year, all of a sudden it's a bunch of cardiology. Next year, it's a bunch of urology. Another year, because of the process that it takes, that once you're doing one, is like, well, let's get that whole group done and get it
It's
in.
you. That's usually the case because what you will find is, for example, I'm going to give an example of dermatology codes for the excision codes. That's a
Mm-hmm.
family of codes. So we have 600 for the malignant excision to 642, right?
Mm-hmm.
So if we're going to change one of those, remember the Medicare budget is neutral. Medicare
Yeah.
was not going to add any extra pennies to the budget to pay for those services. So if we change one code to make it a little bit more complex, somebody in there has to give up something. So it's just best to take the whole family and say, let's look at all this so that we can align them correctly so that when we submit this, they get approved. And if we take more money in dermatology, some other specialty is going to be giving up something. So we
Yeah,
try not to do that, trying to work together. You know, I
that's good.
always think about that process like we have like 26 specialties. All of them are sharks. And they've been placed in this big tank. And it's survival of the fittest. They've got nothing else to eat but each other. So go figure.
So we have to play well together. Let's
We
play
have to
nice.
play well because next time you're going to get eaten.
That's right. It'll be your turn next time. Wonderful. All right, so let's go ahead. I'm going to start pulling up some of the things we wanted to talk about. So, and I just picked some common derm things. A couple of the things are things that kind of annoy me. But the first thing I wanted to bring up, the biopsy codes, with the biopsies, they're from 11102 through 11107.
Mm-hmm.
And when they were redone, and did into the little family that they have with the add-on codes, what I still see, because that change has been a couple years now, and what I still see is people misusing the way that they report these codes. Because it used to be, it didn't matter what kind of biopsy you did, it was a biopsy. You just coded it, how many did you do, and you were done.
Mm-hmm.
But now, because of the different work involved in the different types of biopsies, now we have the tangential, we have the punch, so now we have them differentiated.
Mm-hmm.
And you can do multiple types of biopsies on a
On the
patient.
same day, right.
And that's something that non-derm people sometimes, don't, when I would discuss these and how you should mix and match with the add-on codes, they were just like, well, shouldn't they all be punches? Well, no, that's not how it works. It depends on the location on the body, what they're trying to do, how deep they want, there's a lot of factors that they take in. So they could do a tangential in one area, which is the shave biopsy.
Mm-hmm.
And then they can do a punch in another area. And so what I see happen most often is that people in that scenario will want to code two base codes. They'll want to code the tangential code, the 11102, and the base punch code 11104. And
No good.
so with the biopsies, it's mix and match.
Exactly. I love nursery rhymes. I don't know how many of us here are like kids in their heart. So the way I look at the biopsies, especially if you're doing different techniques on the same date of service and they're being performed by the same provider, is I look at them like, you know what, it's going to be IPT. So if a physician does an incisional biopsy, they also did a punch biopsy and a tangential biopsy. Think about IPT. The eye, this incision, is more complex. And because it's more complex, it holds high RVUs. So that's going to be your base code. So that will be your 11106 base code. And everybody else, you're going to use that add-on code. The next value, highest value code, will be your secondary code, which will be your, in this case, patch biopsy, for example, 11105. And then your tangential biopsy is going to be your 11103. You can only report one base code on a single date of service because remember, there's only one first lesion. There's not two first lesions. You can't have two firsts. And the other thing that I also like to encourage people is when you're documenting, they tend to document a shave biopsy. There is nothing called a shave biopsy. There's a technique called shave. So if you document and you indicate you did a shave biopsy, there's a possibility if somebody looks at those records at a later time, they might downcode you to a shave removal, which would pay you less, which would be the 11300 codes. So you always want to indicate, I did a tangential biopsy, or I did a biopsy, skin biopsy by shave technique.
Yep. That's what I teach my derms to do it. Say it's a biopsy and then how. So biopsy by punch technique, biopsy by shave technique,
Exactly.
biopsy. Yeah. Because yes, it's an issue that I have noticed. Just like with SKs, some of them will say it's irritated SK versus inflamed SK, and I'm finding now that some payors are saying, well, irritated is not the same thing as inflamed.
Very different. Very different. But try and be specific.
So yes. So if you want that reimbursed, so inflamed SKs you can report and get paid for.
And that's what the code
Irritated
descriptor says.
SKs, you know.
Sometimes you just you just need to look at the code descriptor and like, what kind of words do I need in my medical record to support the medical necessity? Look at the local coverage determination. What's the payer talking about? Or the
Yep.
payer coverage bulletin. The other important thing I wanted to mention, Betty, while we're at the on the biopsies is I get a lot of questions where people are asking, well, I did an ear biopsy, a biopsy on the ear, and I also did another skin biopsy. Or I did a biopsy on the eyelid, and then I did another skin biopsy. We always have to remember that those anatomic specific biopsies are there for a reason. The work is very different from the skin biopsies. So, for example, let's take an eyelid biopsy. It's an incisional biopsy. When we're talking about incisional biopsy, we're talking about typically an excision. So you're going deep down, you're doing a wedge, for lack of better terminology.
Mm-hmm.
And you have to have touched the lid margin. If you haven't touched the lid margin, you cannot build a 67810 biopsy at all. Then what you're talking about, if it's, I don't know if people can see me, if you're take a skin lesion biopsy on the top of the eyelid, that is a skin biopsy. So you would build that based on the technique you used with the skin biopsy code. Now, when we talk about the NCCI, and I know we're all over the place, so forgive me, please.
No.
When we talk about the skin, the eyelid biopsy, 67810 or 69100 for the ear biopsy, if you did the ear biopsy, and you also perform a skin biopsy someplace else, can you build those two together? Of course you can. Just make sure you check the NCCI edits and you use the appropriate modifiers. I know for sure if you do an eyelid biopsy and an ear biopsy with a skin biopsy, you don't need a modifier. They're mutually exclusive, so you just build them all clean. Yep. So, but it's important to read the code descriptor, understand what is included in that description of the work that has to be performed before you choose the biopsies. Those anatomic specific biopsies are audit triggers. Basically, the payer knows I'm going to be paying a little bit extra than a skin biopsy. So if you did an eyelid biopsy, you better have done an eyelid biopsy and document it, because I'm definitely asking for that medical record documentation so I can verify that this is actually was performed.
I see that with the lip too, where Indeed. It's like, are you talking about the actual lip or, the skin by the lip? Be very specific, because it can make a difference in keeping the correct payment or having to pay something back.
Indeed. So when you're doing the lip biopsy, for us who have big, thick lips, it has to be within the vermilion border. It has to be within the vermilion border. That's when you can report a lip biopsy. If it's on the upper lip, on the skin here or around here, you technically have a skin biopsy, basically based on the technique that was used.
Yep. So pay attention for those of y'all that code both in dermatology and not, if your physicians sometimes do these types of things, that, just saying it was a lip biopsy is not gonna lead you necessarily to the correct code. You need to look at the documentation and see that they're specific. If it's not, take it back to the doctor and ask, because they may need to do an addendum in order for them to be paid correctly. But, I've tried, to teach the physicians when I talk to them all the time, that don't throw on like lip biopsy with the lip, and just kind of put the code in there for the higher value thing, that, make sure with what you're doing that it's going to substantiate and hold up. That's the biggest thing. It's not getting paid. You can get paid for anything. You send in a claim form, you get paid for anything. Exactly. But it doesn't mean you're keeping it. So, that's what you have to be careful of, and make sure that your documentation, I always tell them my new little thing, Faith, and I got this when I was speaking in North Dakota, and you can use it if you want, is ink what you think. So that's what I tell the doctors now, not because when I used to do, if it's not documented, it's not done, they'd get mad. I was like, are you telling me I didn't do it? I'm like, no, that's not what I'm saying. So then, I started, well, what's a different way I could do that? And so the ink, what you think came around, and I was like, oh, I like that. So, I'm like, make sure it's all in there and it's complete. So
And the neurons should keep firing. Don't give up.
I know.
Keyboard. Yeah, and it's very important because that documentation is the only thing that's going to hold up when
Yep.
questions arise. In case there's a new sheriff in town who decides they
Yeah.
want to look at your medical record documentation, and I
Yeah.
hear a lot of practices where they say, well, my practice management software chooses the codes for me. Well, it depends on what you put into the system,
Yep.
so be specific. And if you can, just disable it because you're
Yeah.
choosing
I
the
don't. I
codes.
don't like those either. Yeah. Yeah.
Right. You're
I
choosing
find
the
some
codes, you're
problems.
responsible.
Yeah, it
Right.
doesn't have a brain.
No,
It's
it doesn't.
it's not an all powerful being there. It's a piece of software. So
Mm-hmm.
it's a sophisticated game, electronic game that you get to play with.
Indeed.
You know,
And you can manipulate it whichever way you want.
yep. If you know the cheat codes, right?
Indeed.
And this is one of my little pet peeve things. I hear constantly, it's a
It's the
shave
shave.
or it's an excision. It's not a shave excision.
No,
It does not exist. Please
exactly.
quit. Just stop it.
It is a shave excision. You have to think about it. When we're talking about a shave, we think about it in terms like we think about a saucer. You're scooping out. You're right on the top of the dermis. You're just taking something real quick. I just want to take this and take a look at it. Or I don't like what it looks like, but I'm going to yank it off. An excision, you're going deep down through sometimes the dermis, and sometimes you might even end up with some fat on the tissue. So if you're talking about excision, you're talking about a different procedure compared to the shave. It's the same thing with the biopsies. When you do a tangential, you're taking a scoop. When you do an incision or biopsy, you're doing a wedge. You're going down into the dermis. So, and it's important that your documentation, I beg your pardon, reflects exactly what transpired because that's what supports that code that you're going to report.
Yep.
There is no procedure called a shave excision. Never heard of it. Never seen
No.
it.
Well, I hear it all the time, but it, it doesn't exist. Um, and then of course modifier 25, we were talking about this yesterday,
My
and
favorite.
some offices get so afraid, of billing it. I have one office is a client of mine, and when I first started working with them, um, they were like, "Yeah, we don't bill it." And I'm like, "You don't bill what? The modifier? No, we just don't bill the E&Ms because they
We
send
don't
us
want
a
to be
letter
audited.
saying that we were an outlier." And I'm like, "Okay." I said,
Well,
what
there's
I
no
want to
winning.
do
Even
is
if you bill it or you don't, you're still gonna get cold on the carpet. So might as well just do it, right?
Well, I think, as long as your documentation is clear, who cares? If they want to ask you for it, give it to them, but don't give up payment just because you're scared that you're going to get audited. Just like those physicians that will all the time do a level 3
I know.
because they don't
I don't
want to
want
do
to
the
bill
course that,
higher.
yeah. So it's
They're
the
gonna
same
ask
kind
me
of concept.
questions.
Don't let them make you nervous, anxious, afraid of billing for what's rightfully yours and work you actually did, or else you can't keep your door open to serve other patients. So with the modifier 25, for dermatology, all the time.
Very
So
typical.
it's nothing to be afraid of. You just need to make sure your documentation supports what
Support.
you're doing. So if they ask for it, just be like, yeah, sure, here you go. Yeah. So what I understand too from friends of mine that work for payors, if they do a little probe, because that's what payors do, send you something and say, hey, can we see, 40 records, they're just looking around to see if those records all have proper documentation. They're not going to keep bothering you.
No.
Because they're going to want to spend their time on the people that aren't documenting properly. They're going to go after where they can get money back. They're not going to keep asking you for records if they're always good.
Right.
So just document it right. So what do you have to say about modifier 25?
My favorite. My favorite modifier by far. Um, you said it correctly. In dermatology, the use of modifier 25 is very typical on a daily basis because of the nature of the services that are provided. I was having a discussion with some CMS medical directors on a conference call, and we're talking about modifier 25 utilization in dermatology. And one of the things that they told me, this is a long time ago, that has stuck with me, is that Medicare, and I'm going to speak about Medicare because I don't know what the commercial payers will do, because, you know, they wake up on the left side of the bed, they do
Oh
something
yeah.
else. Tomorrow morning, they're in a different mood. So you just have to start all over again. What they said that stuck to me with me was, we want to pay you for the work that is done. So number one is you have to perform the service. Number two, document the service and then bill for it. They're not in the business of not paying you, because we always tend to quote unquote vilify Medicare, or they just don't like paying for service. No. They want to pay for the services that were realistically performed, they're medically necessary, and were documented appropriately, and then billed out to the insurance. In dermatology, it's very typical to do an evaluation and then a procedure during the same time. The only thing to keep in mind, and this makes it a lot, everybody that I have spoken to, including physicians, they learn very fast how to delineate the modifier 25 from the actual procedure that they're doing. You want to ask yourself as a provider, whatever it is I am doing, can it stand on its own merit? That's the first question. If I take away everything that's related to the procedure, would this documentation stand on its own merit? Is it related to the problem that I'm actually doing the procedure for? And if it does relate to the procedure, did I go above and beyond? Because remember, every procedure code that is created has a pre-service, an intra-service, and we have a post-service. The pre-service is a hi Faith, welcome. How's the weather? Did you play golf last week? No, I didn't. Oh, so what brings you here today? Well, I got this thing my husband said doesn't look real good on me. I need you to yank it off. Oh, really? So how long has it been there? There's my review of system, right? We've already spoken. Now we're talking about the HPI. Oh, I see. I think this could be this, but I'm going to do a biopsy, or I'm going to do an excision, and then I'll send your tissue for histopathologic review. That's the procedure. So the doctor comes, and dermatologists are hands-on people. They come, they touch the lesion, they palpate stuff, and they ask you other questions. That is your E&M service right there. Now, today with the revised coding guidelines, it's very easy to report an E&M. Doc says, yeah, I'm going to do a biopsy. I'm not sure what it is. I just don't like what it looks like. And we're going to take it for histopathologic examination. But in the meantime, guess what? Here's a prescription, Faith. So you can take this, apply this once a day before you go to bed for the next 10 days. And when the results are back, I'll let you know what's going on. So now the physician has gone above and beyond that procedure that they were performing by now managing my medication. So the prescription that they're going to give me, of course, they're going to tell me what they expect it to do to me. If there's any side effects, how am I supposed to handle that? When should I call them to say I'm having problems? How long should I take to take that medication and report back? That's part of all the prescription drug management. That counts. So even though it's the same lesion that they're going to do a biopsy or an excision on, now we're talking about the management, which now if I tie that to my lesion, gives me that E&M service. Does that make sense?
Oh yeah, and that goes to the point of where I get a lot from derm. Usually, when the patient comes in, they don't want to come back. They just like do everything now. Just go ahead, have at me, right? They want you to do the biopsies, the freezings, So when that happens, it's pretty easy to
Because you've got
say, okay,
multiple
this
problems.
E&M is for all of that stuff, like the SKs and the stuff that we're, the cherry angiomas, the lentigines, when we're doing and talking
Where
about
I
those
told you
things
to go and use sunscreen.
versus the
Right.
procedure.
Exactly.
But when it's the same thing, like the
That's
AKs, where they'll have some AKs frozen, but they treat other AKs with a topical chemo. And that's the only complaint the patient has.
That's
So
a
you
tough one.
have a procedure, and you definitely have a different over and above, E&M going on, because they're not even the same AKs, right?
Exactly. You have two
So
different lesions because you
one
got two different
diagnosis code.
problems. One diagnosis code, but again, there comes the say, pictures don't lie, right? You got wrinkles, you got wrinkles. So if you take those images in the practice and then you indicate this is the one that we did an excision on or a distraction on, and here's the one we did topical 5FU for the
Yep.
patient, delineate so that somebody who doesn't code in dermatology, when they have an opportunity to review your records, they can make sense. Because remember, the codes tell a story. It's like a journalist. You
Yep.
know, they tell a story of what transpired during that encounter where the auditor was not in that room. And I know we always get, I'm that kind of patient when I go for my skin check. I'm like, oh, by the way, doc, I got this. Oh, did you also have some vitiligo here? You know, they're like, Faith, we have 20
I
minutes talking about
I
all.
only have so much time.
Do you think you can schedule another? No, 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 I don't have time. You know, so we get those, and those are the easy ones because you have a slew of problems. The ones that you did with that dealt with the procedure, you can separate those and put them on the side automatically. But then
Mhm.
take the ones that we are just talking about, and there's education on how to manage them, and those can support your separately identifiable E&M service. Now, remember, always remember what Modifier 25 description is all about. That's
Yeah.
what's going to carry the day. We do have some payers who said, well, since the AMA did these revisions to the E&M services coding guidelines, everybody and their father is building an E&M service. So you know what? If your patient was in here 10 days ago, 60 days ago, or 90 days ago, it was the same diagnosis, I am not paying you for that extra E&M when you do a procedure. In our case, what they don't understand is that I said, remember on the onset, I said we have the largest anatomic
That's
system.
right. We got a
There
lot of
is the
area to cover.
diagnosis. So it would be the same diagnosis, but different anatomic location. You know, I would be talking about the lesion on my hand, the other one is on my arm, but it's the same extremity, right? So I'll be using the same diagnosis code. That's where those images come in.
Mm-hmm.
And what they have said is if I don't pay you, you need to prove to me that this went above and beyond. Or if you prove to me and I still don't get convinced, I'm only paying you 50%
Yeah.
of that E&M service. So that's where the documentation comes in. You want to make sure that I mean, we don't expect our physicians, our PAs to write a novel, but we want information that is succinct, very
Yep.
deliberate to explain what transpired during that encounter.
I always
I
tell
can
them,
see
give
some
me the meat.
Barbara says, I am
Uh-huh.
that patient who is the by the way, doc, when the doc is opening the door.
I was just gonna say, I tell them, give me the meat, not the fluff. That's what I'm looking for. You don't have to be, going on for 5 pages about, that, like you said, they not just that, did you golf or what's your average and how many, I mean, we don't need, that's not what we're looking for.
No.
Just get to business with it. Visit with the patient as much as you want and as much as you have
Mm-hmm.
time for, but you don't need to be putting all that stuff in there. You need to make sure you're driving it to the stuff that's going to support what you're
It could
asking to be paid for.
it could be as much as 3 to 4 sentences, and that should be succinct to drive the
Yep.
message home.
And Jennifer has a comment here. Hey, Jennifer, about some diagnosis codes not differentiating the site in all instances. So, it's
Documentation.
all about the documentation.
Mm-hmm, mm-hmm. Thank you for agreeing with us.
Yeah, or else we would just turn you off. So, um, and then the only, let's see, what else do from a standard topic, just two with repairs. I just wanted to really quickly with repairs because I know that is another thing that I see people not paying attention to. That's how I know they don't look at the codes. They
No.
just get the pattern in their head.
Uh-huh.
Watch in repairs because the same body area in a simple repair in that code might be a different family of codes under the intermediate repair. Like they include the hands and feet in the simple with the arms and in intermediate, they
Different.
don't. It's in a
That
different section.
anatomic location actually moves zip codes. They move
Yep.
into a different zip code. So, and that is so true, Betty, because what I've also noticed is when we look at our excision codes are very consistent. Everything is exactly where they're supposed to be. The same zip code, same sizes, blah, 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 regardless of where the location is. But once you get to the repairs, you find that the zip codes seem to move around. So it's always important to pause for a second and look at the code descriptor, make sure that the groupings are correct. Because otherwise, you might be reporting an excision that was done on the upper extremity, and you choose a code for a lower extremity. And those two are not telling the same story. And the pair is like, wait a minute, how did this happen? When did you do the defect? When did you create the defect on the lower extremity? And now you're closing it? How long ago? They look back in their data and it doesn't exist.
Yep.
So it's very, very important. And one other thing that we always have to remember with the repairs, and these are the simple, intermediate, and complex. In dermatology, we don't often report the simple repairs because the simple repairs are automatically included in every procedure that we perform, except when you are performing Mohs surgery. When you do Mohs surgery, you can report a simple repair if you have performed it, right?
Right.
Think about the anatomic location. Even though you have multiple excisions that you have performed, when it comes to the repair, if you have a repair using the same technique and they're in the same zip code, I call it, the same anatomic grouping, you can add all those repairs and report one of the highest codes based on the size that you end up with after you've done your calculations. So that's very important to remember. You don't have to report multiple repair codes.
Right.
It's the same thing with the flaps. It's the same thing with the graphs.
Yep.
So it saves us some time trying to figure out where. But if you have different zip codes for the repairs, repair each one individually. And then the other thing I wanted to point out, talking about repairs and connecting those back to the excisions and the procedures that we use, you always have to remember that you have to figure out who's your dancing partner. Who is the claim going to go to? Some payers might, in fact, some Medicare payers might even say, I don't want you to bill me the excisions as units. Because remember, the way the codes are described, they describe per lesion. They don't describe a slew of lesions. It's not multiple lesions. So they might want you to report individual lesions on a separate line. And there may be circumstances where you end up reporting the same size lesion, same anatomic grouping. All of them are on the left arm, but they're the exactly same size. So you're reporting the exact same code. Again, think about who your dancing partner is. Do you use modifier 59 to differentiate because you don't want that code to be denied, the second one to be denied as a duplicate? Medicare has said, give us a Medicare modifier 76, which says this is a repeat procedure. It wasn't a mistake, so pay me for both. If you go to the commercial payers, on the other hand, they might say, we don't want 76, give us a modifier 59. So you just have to know where your claim is going, and then you bill your repairs separately. And then
with the 59, I tell people, when you look at it from an NCCI standpoint, if you run those through the edits, like a 11401, and put it in there twice, it's not going to show as bundle.
No.
A code doesn't bundle into itself.
No, it doesn't.
So, that's where I see from a lot of they're like, no, 59 is not, because it's not a bundling thing. So you have to know your payor contracts.
Exactly.
Like which one do you want, or the X modifier? Maybe they want the XS.
That's what I was going to say. Remember those X modifiers? And oh my goodness, I was like, what in heaven's name are we talking about here? Because we went back to a CMS and said, this doesn't even reflect what we do in dermatology. So Medicare has given us an out in dermatology not to use the X modifiers, the XESPU modifiers, because they really do not, especially when you have those repeat procedures. There is no modifier there that describes that kind of circumstance. So unless a Medicare contractor specifically says, I want you to use an XESPU modifier, we typically default to the numerical modifiers. 59, 76 are the ones that we use most of the times, because we did go and have a separate discussion and negotiated for an out.
Yep. And Jennifer, again, there was another one from her. She's saying that, they did create these for a reason. The full description is important. But Jennifer spoke on derm stuff at HealthCon. So she talked about repairs and stuff about the guidelines and stuff like that. So
In fact,
she
we
just recently.
did the repairs that were done in 2022, Jennifer, that you're talking about, are specific to the simple repair code. Because in dermatology, you don't report that often enough. For those that are reporting it with Mohs surgery, we used to have Mohs surgeons who would say, you know what, leave it for secondary intention.
Right.
I build a simple repair. And AMA is like, not so fast. You know, you got to put some stitch in there somewhere. Find a layer with it has to be one layer, but put a stitch in there, or in combination with something else, some glue or and a stitch,
Right.
to be able to report a simple repair. The repair codes, intermediate and complex repair, were revised in 2020. And with those revisions came new instructions which said, you have to also, it's not a requirement to be able to bill for the CPT code. However, most payers are actually seeking to review the medical record because they want to differentiate between an intermediate and a complex repair. And the only way they can differentiate, because it's basically two layers of closure, right? It's the undermining that is performed. So what we encourage telling all the physicians or the providers that perform intermediate or complex repair is, make sure you document how much undermining you performed. With the intermediate, it's up to the distance of the defect on both sides of the defect.
Yep.
If you undermine half the distance of the defect on top and the other half at the bottom, which equals the total length of the defect, does not constitute undermining for an intermediate repair. It has to be at least on one side perpendicular to the defect. Make sure you indicate that. If you undermine anything extra over the length of the defect, then you have done a complex repair. Or when we're doing undermining on the nose and you expose some cartilage or the ear or sometimes on the eyelid, that in itself, because you've exposed the vessel or you've exposed a cartilage or a bone, that will automatically qualify as a complex repair. But make sure that is included in the medical record. I know for sure United Healthcare, Aetna, and Humana are asking for medical records just so they can verify, did you do an intermediate or you did a complex? Because you built for a complex repair. Let's see what you documented.
Yeah. And that's where, again, pictures, if you take a picture of this big old defect, and you can see, what they're taking a look at, that's where, the picture is worth 1,000 words thing sometimes. Indeed. So it's always really good to take those visuals and to store them in the medical record. Some of the we got a couple of people that really like our X modifiers here.
I know, Pam, more power to you.
Yep.
I love the X modifiers just like the next person. However, they don't work in the environment I live in. But if you are in my environment, unless a payer specifically asks you to use it, most commercial payers might not even ask for them. It's a Medicare contractor that's good, because those were specific to Medicare contractors.
Yes. Well, until they couldn't figure out how to explain them.
Indeed. That's what I said. Remember, I said, it just depends on who's in charge today and how they feel. Let me just throw something at the health of medicine and see if somebody's paying attention.
And I just wanted to
wait, what are you trying to tell us here? What are you trying? Oh gosh, maybe we should have thought about this a little bit more before we put it out.
I know that was the biggest. I thought that was that was so funny when we would discuss it and we would talk, because I had physicians and people asking me about the eczema. Should we use them? And I don't want to get in trouble and blah, blah, blah. And I said, well, calm down. Medicare has already said that,
you can use them. They're available.
You can just ignore it for right now, because they couldn't explain what the XU modifier meant. They could not explain their own modifier. And I just got such a kick out of that. I'm like, maybe think it through a little bit.
It's not the first time Medicare has done something.
No, it's not.
They like to throw things out just to make sure.
They do. Yep. Well, look at the E&M changes, right? For the 2021 guidelines, it was supposed to be before. And then they were going to do just the 3 level of codes when they were trying to help the physicians by bundling all the E&M codes together. I was like, that's just not going to work.
Look at the modifier of FT modifier. Look at modifier 93. If you look at the modifier itself on its face, you think, oh, everybody can use this modifier. And I know we get a lot of information that was saying from physician offices asking us, should we abandon modifier 25? I'm like, no, 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 no. Nobody said that. No,
Yeah.
but look at this modifier. I'm like, I know, but if you go in the final rule and look on page whatever, three pages down after they introduce the modifier, that's where they say, oh, these are specific to mental health and behavioral codes. And then they estimate, oh, this is specific to critical care. Well, it would have been helpful if you put that at the beginning so we don't have to waste time with it if we don't do
Oh,
good.
yeah. Yep. People use a modifier because, yeah, that's what I've told. Just because they have the modifier doesn't mean that, it's something you're supposed to be using for whatever you're coding today. Make sure that it's the right thing. Just because you see it doesn't mean you have to be slapping them all over the place.
Right.
Because then what'll happen is the payer system gets it and doesn't know what it is, and they kick it out because they're like, I don't know what that is.
Exactly.
It doesn't belong there.
And you know what? It would be helpful. When we're using our practice management software, this is some of the feedback that we should be giving back to the tech companies, for them to give us a full description of the procedure code or the CPT code instead of the short abbreviation. Yeah, it's easier for us to pick it, but most of the times, if it's the physician picking, they don't have time. They're running to get into the next room to see the next patient.
Yep.
They don't have time to figure out what the whole code actually is talking about. So that's where we tend to find a lot of codes picked out, and then you get back to fixing that.
And I see just a couple quick examples of that is I was auditing a large dermatology practice, and on their encounter forms, this was back in the day where we still used encounter forms, people. So I'm again aging myself here, but on the encounter form, it had, I'm going through and they're doing AKs, the derm practice. So they do a lot of AKs, and they were always billing them wrong. I'm looking. And I'm like, why did they keep missing? They were missing all of their units for the add-on codes. They would do 8, 9, 10 AKs, but bill the 17,000 for the first one, and then the 17,003 for but just once.
One unit.
And so I was like, okay, well, I looked at their encounter form, and their encounter form on it, because of space, had 17,000 for the first lesion, and then 17,003 lesions 2 through 14. Not each. They didn't put that word on there. So the physicians all thought, well, it's 2 through 14, so I did that one too.
Yeah.
So I'm like, how much money
you have left on the table?
When I was going through my report with them and showing them this on a PowerPoint, you could just see the blood draining out of half their faces, and they're turning white. And one of the physicians is just like, that's one of my patients. I was like, yeah. And he's like, do you mean every single time? I'm like, yeah.
Yeah, like, that's painful.
I've been here for 4 years. I was like, well, so it, you really have to pay attention to those kind of things, because that's a lot of revenue that you're leaving on the table.
Do you think they were conflating the benign lesion distraction codes with the pre-malignant? Because with the benign lesions, if you remember, those codes basically say 1 through 14, then there's 15 and above. So maybe that's what the physicians were thinking.
I don't know. I think, maybe they thought it was just all grouped, it's terrible. It was bad. It was, but at least it was the add-on code. So although the loss rate, it wasn't as huge as it could have been if they were basic, you know what I mean? So I tried to silver line everything. It's like, well, now you know.
You know what? I'm sweating right now just thinking about how long was that going on? And
for
then
him,
you start thinking about $38 per lesion. I don't know how many
4 years.
4 years times how many lesions that they had. Oh my goodness, that's a lot of money.
Yeah.
Mm-hmm.
It was bad. It was, but they were so glad, so my audit, and it paid for itself. That's one of the things when I talk to people, and audits don't have to be tens of thousands of dollars. You don't have to look at 800 records to try to find, especially for dermatology, there's a pattern of things that we do. You know, and so, you know, there's, you know, certain groupings of codes and certain procedures we do a lot. You want to check on those first, see where you're losing big dollars. And a lot of times you find more that's left than you did that's over coded or miscoded. A lot of times you find undercoding, like the 3 thing where I'm just like, no, stop
And
that.
the E&M is a low-lying fruit.
Yes.
That we all have to pay attention to, because if you have enough information to be able to report that separately identifiable E&M, that's money that's being left on the table. I can't emphasize that enough.
Yep.
That's low-lying fruit. It's easy today to be able to report an E&M service. Just make sure that you look at the documentation.
Yep.
Our providers might not notice that, and some of them, like you said, are like, I don't like to bill the modifier 25 because CMS says whether you bill it or you bill it incorrectly, or you don't bill it at all, we're still coming after you. So might as well do it. If they're coming after you, right, it's worth the trouble.
Yep.
That's the way I look at it.
So we have about 5 minutes left because we've been chit-chatting so well. So if people have some questions, if they want to put them in the chat, everybody's been pretty interactive today and putting some stuff in there. So if you have some questions for us, go ahead and throw them up in the chat so that we can address them, anything specific. But in talking to about that issue that you just said, well, I'm waiting to see if anybody puts anything in there for us, is we had a case where there was a physician that just undercoded their E&Ms because they didn't want to get in trouble, and they just kept doing it and was over. And they did get a records review because they were an outlier. It doesn't matter what level you're an outlier at, you're an outlier. So they did a random review of some of their stuff, and they got a check back from the payor because they undercoded a lot. And so when they came to, they had to, because they do, if you have undercoded your service and the documentation indicates you did a higher level, they have to pay you for that. Just like they want their money back.
They also,
if you did something else, they have to pay you. But along with it also came a note that said, stop it. And if you don't stop it, we're going to fine you for administrative burden.
Yes.
Because now we have to keep looking at your stuff because we know you're not doing it right. And we know you're getting underpaid. So we have to keep checking on you until you're doing it right. And that's going to cost us time, us revenue, us people hours. And, you know, so stop it.
And that fine can be even more expensive, because what Medicare can do is they will say, well, since you're so kind enough to save the Medicare program a lot of money by undercoding, it doesn't matter, next time when you code correctly, we'll still pay you at the regular lower rate that you're constantly giving to us. So now they put you in that category, and now you can't even collect the money that you are owed because you've been doing it wrong the whole time. And if you continue without fixing, if they've called you out and you continue making the same mistakes, they could even bar you from participating in the program. So it can be very, very painful.
Document what you did, code what you did, get paid for what you did. You know, that's simple. So, yeah. And Jennifer has a question here. I've been told that in audits, often the ICD-10 is not in the scope since the CPT carries RVU or the money. And traditionally that was what on the physician side, on the prophy side, yes, we always paid attention to CPT, not so much ICD-9 back then, you know, so not so much the diagnosis coding was much more driven to CPT. So what should we express to our auditing clients about how ICD-10 does affect the reimbursement? My suggestion, and then I'll ask you for your tip, Faith. My suggestion, how I talk to physicians and my clients about it, is that medical necessity. You know, if you want to show medical necessity, you know, they're looking for specificity in ICD-10. Also, if HCCs, if you're involved in risk categories at all, you know, that's going to come into play that you're building, and that definitely has an effect on your reimbursement. So, and it could be a reason for them to, you know, audit you if you're using a bunch of unspecified codes. For me, the payers look at stuff, you know, in their systems when they have it to do the data mining. If they see that this one practice is using unspecified codes all the time, they're going to say, well, if they're not documenting that, what else might they not be documenting? Maybe these procedures they're billing us for, maybe their documentation is not so hot for that either. If they don't know, what this is, how are they treating it? So that's to me how I would do it. Faith, do you have any kind of comments on the ICD-10?
I totally agree with everything that you just said. And the other thing that we also have to think about, especially in dermatology, our specialty is very visual. Everything we do, we look at. Unspecified codes are not so hot for us because the payer is like, well, before you remove this, you don't even know where it was located? Come on now. If you treated this patient, you know where this thing was. You must have yanked it off and you held it in your hands. Remember what I said earlier. We are always telling a story. The codes we report are telling a story. So the diagnosis code justifies, rightfully so, the medical necessity for why you provided that service that you rendered. Whatever the procedure or the service that was rendered has to be justified by the diagnosis code. And most of the coverage policies, at least the ones that I've looked at, have a slew of diagnosis codes listed. If you report these codes, group 1, with these procedures, we'll pay you, no questions asked. I haven't seen an unspecified code in there. If you report this code, which is probably unspecified or it's an other code, please add a code from group 3, which shows me the symptoms that makes this medically necessary to be treated. Then report it with this procedure code, and I'm going to pay you. So I would encourage everybody to take a moment and make sure that the diagnosis codes are supporting the procedures that are being performed and the reason that service is being performed. Otherwise, the payer is a little bit antsy to write a check knowing they don't know what they're paying for.
Yeah. Yep. Yeah. The one that irritates me the most in dermatology, because we don't have bilaterals, you just have skin, is when they have bilateral codes and you're using the unspecified. That really sends me over. I'm like, seriously, you don't know your right from your, come on, really.
Recently, I looked at
yeah.
the chart and it was basal cell carcinomas, multiple basal, different locations, and they were using the unspecified code. I'm like, why did you use unspecified? Didn't you know where the basal cell carcinomas were? Well, they were all over the place.
Yeah.
Well, we have a code for each of those anatomic locations. So we got 12 spots electronically to add that. Go to town.
Yep.
Put the codes in there and you'll be just okay. I know. I don't even like to talk about unspecified codes. There's a reason we transitioned from ICD-9 to ICD-10.
Yes.
And the payers are constantly upholding that policy to make sure that this diagnosis coding is reported at the highest specificity.
Yeah, I think they gave us a little leeway the first couple of years because it was brand new and there were 60,000 codes and it was so big, but they're starting to tighten up on all of that and the guidelines. And so for people, I also, also suggest refreshers on their ICD-10 just to make sure, you're paying attention to all of that stuff in there with instructional notes and everything else. So it has to marry up with your CPT, right?
Yeah. I had one quick tidbit before we leave.
Yes.
I know we're over time, but I just wanted to make sure that I mentioned this because this has been coming up very often. I get questions with, we did an excision and the physician felt or clinically thought it was a malignant lesion.
Yeah.
And we billed it as a malignant lesion. And then the biopsy, the tissue comes back, the report, histopathology comes out, it says it's benign. And now Medicare is coming back and they're looking for their money. What does that mean? I always encourage everybody. I said, if you're going to touch a malignant CPT code, make sure you have histopathologic reports to support that malignant diagnosis that you're going to report. Because remember, the pathologist is also billing for his services for the same patient during the same period. So Medicare is following the money. Yep. So you're claiming it's malignant when the pathologist, who is supposed to be the final say, is saying it's benign. Yep. There's a disconnect there. So if you're not certain, even though the physician, I know dermatologists are trained to look at tissue and can tell whether it's malignant or not. Yeah. Wait for the histopathologic report to come back before you slap on that malignant diagnosis in the malignant CPT code.
Plus, you're tagging the patient with cancer when they don't have it.
Exactly.
So that opens you up to liabilities in other ways. So, you always make sure, especially for those kinds of diagnoses, it's not something that you're just, oh, well, we didn't mean it. Or, oh, well, if you're refunding and rebilling and trying to switch around all the time, you're going to be a target.
Exactly.
So,
And you know how Medicare operates. Medicare says, oh, we overpaid you. We're just going to give you, send us back the difference. No, they want you to send everything back and then you start all over again. So that's an work to the whole process. So don't do it.
Yep, exactly. Well, thank you very much, Faith. We're getting some, Diana, thank you. I'm glad that you enjoyed it. And Eileen has given us a thank you. And a lady follows up with her, be as specific as you can be. It will help the revenue. So gotta love it. Thank you. Thanks everybody for participating today. Faith, thank you so much for being a guest.
Thank you so much. This was so much fun. I
always love talking to you. I said I do. I love listening to you talk all day. I love your accent, so I can listen to you. People are like, well, I don't have an accent.
You do have an accent, Betty. And listen to me. I'm the one telling you. So, and
Jennifer, oh, that sounds great, Jennifer. Yeah. That's a good subject. So, and some good people. So everything's really good. So thank you. We appreciate it, everybody. And we will see you in a couple weeks. And I'm sure Faith will be back on with me again soon.
Of course.
In fact, I'm putting together like a networking session. I thought that would be kind of fun. So I'd like to have you, and I know Jennifer's on here watching. So Jennifer too, to do one just on networking for people.
Perfect.
So I figured that would be a fun thing for some of us to get together and do for people. Yeah. So, okay. Well, everybody have a great rest of your day and have a great weekend. Thank you.
Thank you, everybody. Have a great day.